Paranasal sinuses usually consist of 4 paired air-filled spaces within the skull, and they have several functions like the lightening the skull, adding resonance to the voice, and in humidification of the air. And they are 4 paired paranasal sinuses divided into the anterior and posterior group. So frontal, maxillary and anterior ethmoid sinuses are considered as the anterior group, and the posterior ethmoid and sphenoid are considered as the posterior group. Here we can see in this image, this is the maxillary sinus on either side of nasal cavity. This is the ethmoid sinus in midline, and posteriorly this is the denoted by this green is the sphenoid sinus, and this is the blue one is the frontal sinus. So these are the sinuses as we can see in this sagittal image. This is the frontal sinus, orange one is the ethmoid sinus, and this green one is the sphenoid sinus. Paranasal sinuses develop from the invagination of nasal mucosa into the lateral nasal wall, and maxillary and ethmoid sinuses develop within the intrauterine period, whereas the sphenoid and frontal sinuses develop after the birth. So maxillary sinus present at birth and it develops within the intrauterine period, and it presents at birth, and ethmoid can also be seen at birth, but they become evident in X-ray or radiologically evident. Maxillary become 4 to 5 months after birth, and ethmoid become the 1 year after birth, whereas the maxillary become adult size at 15 years of age, whereas the ethmoid sinus become adult size at the age of 12 years. And sphenoid sinus and frontal sinus are not present at birth, and they become evident radiologically by the 4 year and 6 years of age, and sphenoid become adult size by the 15 year, whereas the frontal sinus increases until the teens. Now the CT protocol for the imaging of the paranasal sinuses is: patient position is supine, scout film is taken perpendicular to the hard palate, so this should be perpendicular to the hard palate. Extent of CT scan is taken from the hard palate to above the end of the frontal sinus, so above the end of the, and it is denoted by this box. And then scan direction is the caudocranial from down to up, so caudo to cranial. Slice thickness is 0.6 to 1 mm, and multiplanar reconstruction is done in coronal and sagittal images to visualize all paranasal sinuses adequately and properly. The osteomeatal unit is the common drainage pathway of the anterior sinuses, that is the frontal, maxillary and anterior ethmoid sinuses, and it is also called the osteomeatal complex, and this is the region which forms the osteomeatal unit. And the components of the osteomeatal unit are the frontal recess, as we can see here, this is the frontal recess, one is the frontal recess, two is the infundibulum. Where is the infundibulum? We can see here is the infundibulum. 3 is the hiatus seminularis, this is the hiatus seminularis. 4 is the maxillary ostium, we can see here maxillary ostium. 5 is the uncinate process, and 6 is the middle meatus. So these three structures forms the osteomeatal complex, and it is the key area of interest in the pathophysiology of chronic sinusitis and the center of interest in the face surgery. Now let's begin with the sinuses one by one. So first start with the maxillary sinus. So maxillary sinus is a paired pyramid shaped. So it is a pyramid shaped structure, air filled cavity, as we can see here. It lies within the maxillary bone which drains via the maxillary ostium. This is the maxillary ostium into the infundibulum. This is the infundibulum. And then hiatus seminularis, here we can see that this is the hiatus seminularis, and into the middle meatus. So this is the pathway of maxillary sinus drainage, and it is the largest sinus among the all paranasal sinuses, and it lies on either side of the nasal cavity within the maxilla. So these are the maxillary sinus. Now the anatomy and boundary of the maxillary sinus. Maxillary sinus is a pyramid shaped structure, as I said, and it has a base on the lateral border of the nose. So this is the lateral border of nose, and this is the base of maxillary sinus. As we can see here in coronal image, this is the base of maxillary sinus, lateral border of nasal cavity, and apex pointing towards the zygomatic process. So this is the zygomatic process. So we can see there is the apex of the maxillary sinus, and floor formed by the alveolar process of the maxilla. This is the floor of the maxillary sinus, and roof is formed by the floor of orbit. So this is the roof of the maxillary sinus. This is the base lateral nasal wall. Base apex is towards the zygomatic process, whereas the floor is formed by the alveolar process of the maxilla, and the roof is formed by the floor of the orbit. So this is the anatomy and border of the maxillary sinus, and the posterior wall of the maxillary sinus forms the anterior wall of the pterygopalatine fossa. So this structure is the pterygopalatine fossa, and its anterior wall formed by this is the posterior wall of the maxillary sinus. It forms the anterior wall of the pterygopalatine fossa. So this is a very important structure, and its anterior wall is formed by the maxillary sinus posterior wall. Like the other paranasal sinuses, they can vary in size. Large maxillary sinus can extend to the alveolar process of the maxilla to point where the root of the molar tooth can project into the space. Now the common anatomical variant of maxillary sinuses. First is the pneumatization into the roots of the teeth. So this is the hyperpneumatization of the maxillary sinus. As I said, there is the pneumatization of the root of the teeth. So root of teeth projecting into the sinus cavity. Now the second one is the antral septation, septa within the maxillary sinus. This is the antral septation, and this is seen in the 44% of cases, whereas the pneumatization into the root of the teeth is seen in the 83% cases. Hypoplasia of the maxillary sinus seen in the 4.8% of cases. So these are the maxillary sinus. They appear small on either side. So this is the hypoplasia, and sometimes total maxillary sinus agenesis can be seen, and exostosis development within the maxillary sinus seen in the 2.6% of cases. So these are the variant anatomy of the maxillary sinuses. Now the second sinus is the ethmoid air cells or ethmoid sinus, and it also developed within the intrauterine life, present since the birth, and it is located within the midline ethmoid bone. So it is a midline sinus. As we can see, this is the denoted by this pink. This is the ethmoid air cells, and they lie between the orbit and nasal cavity. Inferiorly there is a nasal cavity, and on either side there is orbit. Ethmoid air cells are the collection of 3 to 18 air cells or pneumatized cells separated by bony septa. So these are the bony septa separating the ethmoid air cells, and they lie within the labyrinth or ethmoid bone, and they are separated into anterior and posterior group by the basal lamella. So we can see here, this is the lamella of middle terminate, this is the basal lamella. This is the basal lamella separating this is the anterior, and this is the posterior ethmoid air cells, and this is the sphenoid sinus. So we can see in this sagittal image, and basal lamella is the lateral attachment of the middle turbinate to the lamina papyracea. And historically, the ethmoid sinuses were subdivided into the 3 groups: air cell, anterior, middle, and the posterior. So nowadays, anterior and middle are grouped as the anterior, whereas the posterior is separate. The anterior ethmoid air cells drain into the hiatus seminolaris and the middle meatus via the ethmoid bulla. So this is the large ethmoid air cells called the ethmoid bulla drain into the hiatus seminolaris and then into the middle meatus, and the ethmoid bulla is also a component of the osteomeatal complex, and ethmoid air cells drain into the superior meatus via the sphenoethmoidal recess. So this is the sphenoethmoidal recess. So posterior ethmoid air cells drain into the superior meatus via the sphenoethmoidal recess. Some of ethmoid air cells have given specific names because of their importance in surgical procedure or involvement in head and neck pathologies. So frontal recess cells including agar-Nagy cells, ethmoidal bulla, Haller cells and Onodi cells. Agar-Nagy cells, they are the most anterior ethmoid air cells as we can see in this image. They lie anterior and inferior to the frontal recess. In sagittal image we can see this is the agar-Nagy cell and this is the drainage pathway of frontal sinus, that is the frontal recess, and they lie within the lacrimal bone and have relation with the orbit, lacrimal sac and nasolacrimal duct, and due to its large size it may lead to the narrowing of the frontal recess and causing the frontal sinusitis due to the retention of secretion within the frontal sinus. Classification of frontal ethmoidal air cells based on their relation to the agar-Nagy cell developed by Bent and Kuhn. So it is called as the Kuhn's classification. This is the Kuhn's classification. So type 1, there is only one cell above the agar-Nagy cell as denoted by this blue color. This is the only one cell lie above the agar-Nagy cell. This is the agar-Nagy cell and this one is the another cell above the agar-Nagy cell. In type 2 there are two cells above the agar-Nagy cell, whereas in type 3 there is a large but single air cell above the agar-Nagy cell extending into the frontal sinus. So its extension into the frontal sinus. And in type 4 there is an isolated cell in the frontal sinus, as we can see here, frontal sinus denoted by this blue color. So in this coronal image, CT coronal image, we can see this is the white arrow denoting the agar-Nagy cell and black one is the frontal ethmoidal air cell. In relation to the agar-Nagy cell there is a single. In the second image type 2 there is double, whereas in the third there is a sagittal image showing extension into the frontal sinus, and in type 4 there is an isolated air cell with sinusitis in the frontal sinus. Now the ethmoid bulla. It is the largest and most consistent air cell of the anterior ethmoidal air cell. It is a component of the osteomeatal complex and it is located posterior to the frontal recess. As agar-Nagy cell located anterior to the frontal recess, ethmoid bulla or bulla ethmoidale is located posterior to the frontal recess. So this is the ethmoid bulla located posterior to the frontal recess. This is also ethmoid bulla. This is the largest ethmoid air cell and it forms the roof of the middle meatus. So it takes part in the drainage of the ethmoid air cells, anterior ethmoid air cells into the middle meatus, and failure of pneumatization of the ethmoid bulla is called the torus ethmoidalis. Now the Haller cells. It is also known as the infraorbital ethmoidal air cells. They are the ethmoid air cells located lateral to the maxilloethmoidal suture along the inferomedial orbital floor. So this is the Haller cell, lies inferomedial to the orbital floor. So these are the Haller cells. And their clinical significance is they become infected with the potential for the extension into the orbit. So if they get infected, they can transmit infection into the orbit and they may narrow the osteomeatal complex, so drainage pathway of the maxillary sinus, as we can see here, and lead to the maxillary sinusitis due to the retention of secretion, and they may lead to the inadvertent entry into the orbit if unrecognized at endoscopic surgery. So they have importance in the orbital surgery or endoscopic surgery also. Now the Onodi air cells or sphenoethmoidal air cells. So they are commonly known as the Onodi air cells and is an anatomical variant of the paranasal sinuses, important due to its close proximity to the optic nerve and the internal carotid artery. This is the optic nerve. These are the site for the internal carotid artery. They are important due to its close proximity to these two structures. Now the variations of the ethmoid roof. The depth of the olfactory fossa is determined by the height of the lateral lamella and the cribriform plate. This is the cribriform plate and this is the lateral lamella. So this height is measured and it is classified according to the Caro's classification, that is type 1, 2 and 3. Type 1 has 1 to 3 mm depth, as we can see in this image, very less depth. Type 2 has the 4 to 7 mm and type 3 has the 8 to 16 mm. So type 3 is the deepest one. So this is the type 3. In type 3 there is very thin cribriform plate and deep olfactory fossa, and it may lead to the injury during the surgery and lead to the CSF leakage. So it has very important role in the sinonasal surgery. Now the third sinus is the sphenoid sinus, and it is the most posterior sinus, as we can see in this image. This is the most posterior sinus. It lies within the body of sphenoid bone and anterior-inferior to the sella turcica, and it is separated by a thin septa, bony septa. So this is the right sphenoid and this one is the left sphenoid sinus. Now the relations of the sphenoid sinuses are the superiorly and laterally it is related with the cavernous sinus on either side and the cranial fossa. So these are the cranial fossa, and superiorly it is related with the sella turcica, whereas the inferiorly with the nasal cavities. So inferiorly it is related with the nasal cavities, and anteriorly also it is related with the nasal cavity and posterior ethmoid air cells. So this is the posterior ethmoid cell air cells, and posteriorly it is related with the middle cranial fossa. Now the sphenoid sinus pneumatization variations. So it is measured in relation to the sella turcica. So in conchal type, so this is the type 1 conchal type, where the pneumatization is more than 10 mm of anterior to the sella turcica. So this distance is more than 10 mm. So this is the conchal type. Presellar type, that is it reaches to the margin of the sella turcica, that is the anterior wall of sella turcica. So this is the presellar type. Incomplete sellar type is the going beyond the sella anterior wall but not reaching to the posterior wall. So this is the incomplete sellar type. So this is the posterior wall not reaching to the posterior wall, and complete sellar type, in this type the pneumatization goes beyond the posterior wall of the sella turcica. So sphenoid sinus pneumatization variation is in relation to the sella turcica are the conchal type, presellar type, incomplete sellar type and complete sellar type. Now the last one is the frontal sinus. So it develops after the birth and its location is the anterior frontal bone. So they lie within the frontal bone, as we can see. These are the frontal sinuses lie within the frontal bone, and there are two chambers on each side, and they are almost always asymmetrical. As we can see, there is a smaller on right side and larger on left side, and they have 3 or more chambers, and this can be only seen in 10% of cases, and it is divided by a thin bony intrasinus septa. So these sinuses are divided by the thin intrasinus septa, and they are usually of midline. Now the drainage pathway of frontal sinus. There is a slight narrowing in the medial end of the frontal sinus, that is called the frontal infundibulum. So frontal infundibulum drain into the frontal recess, and this drain into the hiatus seminularis, and this will drain into the middle meatus. This region is the frontal infundibulum, then frontal recess, and this will drain into the hiatus seminularis and the middle meatus. So this is the drainage pathway of the frontal sinus. If you like my video, then like, share and subscribe. Thank you.